Good morning. We'll just give it a moment for everybody to show. Hmm. All right, I guess we should get going. All righty, good morning. Okay. So question is, what is this arrhythmia? Um, what is the workup? And what do we believe is the natural course? And should we be treating this? And if so, with what? So why don't we ask Dr. Mukhopadhyay what she thinks?
Good morning, Dr. Pass.
Oh,
Uh, so um,
the newborn.
I'm Lulu. Can you hear me?
Yes, can hear you very well.
Okay. Um, okay. I'm looking at the rhythm strips at the bottom, looking V1, 2, and V5. The first 1, 2, 3, 4, 5 beats are sinus, and then for the next few beats, the QRS morphology changes.
Mhm.
And trying to think if I can see for the third of that beat, I think there's a small P wave, a retrograde P wave. Uh but that's like after the second beat, and the same for so there's a retrograde P wave after the QRS complexes in the second and the third of those beats. And then no, I can't see it in the fourth, fifth. I can see in the sixth and seventh. And okay. So the
How would you describe the relationship between the QRSs and the P waves then?
the P waves are following the QRSs, and I would say
But didn't you just tell me that some of them they aren't?
yeah, and that so they're not most so the P waves are some of the QRSs are not followed by P waves, and some
So,
of them are,
so
and
let's use some medical terminology. Are they associated or dissociated, do you think?
um they are inconsistently associated with the
Okay,
QRS.
I'll accept that answer. Um,
Yes. And
but there is definitely some element of dissociation.
yes,
They're
yeah,
not fully associated, right?
yeah.
Okay.
And uh, seems like so I would think this is
And are those wide beats the same rate or a little faster than the
I
sinus beats that surround it?
think they're faster than the sinus beats.
I agree. I think they're a
Yeah.
little bit faster. Not massively so, but I agree they are faster. So what do you think that is?
Did this
You're
newborn
very
have
good at, you've been very good at describing the morphology. So if we didn't live in an era of cell phones or fax machines, I'd feel very good knowing from you what was there. But what do you think this is?
and did this newborn have any surgery, or is just like
It's just a plain old newborn, just born, hanging
uh
out in the well baby nursery. Someone heard an irregular heartbeat.
Okay, so given the fact that the QRS morphology is like wider than the normal sinus morphology,
Yeah.
and it's also faster, I would think it's some sort of like an accelerated ventricular rhythm, and then it becomes normal. It's become sinus again, and then it happens again. So
Mhm.
it's like this intermittent thing that's happening, and
That's right. That's
yeah.
right. So this is an accelerated ventricular rhythm, or if you want to call it VT, you can. It's various definitions for how you determine between those two, but ultimately those are just nomenclature. And the reason you know it's ventricular, right, again, is as you said, the QRS morphology is completely different than the sinus beats, right? These are very nice examples in the rhythm strips where we can clearly see in three different leads that the morphology in sinus and the morphology in this rhythm are completely different. And again, you're right. There does appear to be some association in some of the beats, and you might even, if you took a caliper out, you might notice that there is a slight lengthening in the R to P interval here. So it could even be like a retrograde wanky box sort of situation here, but clearly there is dissociation. This is a very nice example where you can see clear retrograde P waves, and it's very obvious that you're not seeing them after every QRS. So this is ventricular atrial dissociation with a wide QRS. And remember the old rule of automatic rhythms in the heart, which is whatever is fastest wins. And so in this case, the ventricular rhythm is faster at points than the sinus rhythm. And so it overtakes the rhythm temporarily. The patient is having little episodes of accelerated ventricular rhythm or VT. So okay, so you got the call that the patient had an irregular heart rhythm. You are the fellow on call. You asked the staff in the well baby nursery to do an ECG. You got the ECG, you've looked at it, you've made this determination. Now you're standing there, you're going to call the attending physician who is going to ask you, what do you want to do next? So what would be the workup?
I would, if there's like telemetry recording over a pe longer period of time, I would review that and see how
It's a
frequently the
good
patient.
point, but you're in the well baby nursery. There's no
Oh, okay, sorry.
But it is that is something I would do for sure. That's a good
Uh,
answer, but you don't have that pleasure,
so
luxury.
typically, as accelerated ventricular rhythm in the newborn is like it has a benign course. It's not usually associated with any structural heart disease. So I would just continue. I would ask, if it was up to me, I would ask the baby to be transferred to the NICU so that I can review telemetry for the next few days so that I'll be reassured.
Okay.
And and depending how frequently this thing occurs, I would probably get an echo just to see how the cardiac function is. Um, and uh, and I would, yeah, I would think this would self-resolve as the baby grows older.
Right.
So I would reassure the parents when I'm talking to them about this
Okay.
rhythm.
So would you treat this?
Um, if it is like due to automatic uh if this is I would get electrolytes to see if they're all fine.
The old get the
And
electrolytes. I've got to tell you, I'm going to put out a challenge for somebody to find an abnormal electrolyte in the setting of arrhythmia. But yes, that is not a bad answer, but almost virtually never is the case. Maybe on rare occasions, someone's potassium will be 3.4 or something, but um, okay. I mean, the other thing is you would, right, your decision to treat would be based also on how much arrhythmia the patient's having, right?
right.
And also what your echo showed. If you had dysfunction, which presumably could be from a tachycardia-induced myopathy, so you might think differently about treating or not treating. Most of the time, we would observe this and try not to treat if possible, because it might actually be difficult to treat this. So just as you said, there are many, many papers on outcomes of PVCs in infants and newborns. This is just one of like 300, an older study from 18 years ago with a very small number of patients, but there are very few studies with large numbers of this. This had 16 newborns with PVCs, and you can see they had in this study fairly high burden of tachycardia, 300 PVCs per hour, which is not, a small number. And CPLT is an abbreviation they use for couplets in this paper. The patients who had couplets, would have 106 per hour. That's a good number. And then there were a handful of people who had actual runs of VT. And essentially what they found was that, whoops, sorry, that if you just had single PVCs, it resolved in their group in 2 months in the majority. If you had couplets, which I guess would be maybe a marker of more ectopy, it took about 6 months to go away. And those who had VT, interestingly, there were very few of them, but they went away in just about 2 months. So you're absolutely right and there was a good follow-up here, 3 to 4 years. So you're right. This is not obviously the best paper in the world, but it definitely reflects what is seen in almost all papers on this topic, which is that this is generally a benign condition, and we would really only treat it if we were worried that the amount of ectopy could result in dysfunction or worse. And the other thing I would say is in terms of the echo, I would probably do an echo also because rarely there are reports of these things called Purkinje cell tumors that can cause PVCs. I've never actually seen this, but the group in Texas has written a lot on this, and it's doesn't come up in the literature as much as it used to, but they will tell you that in MRI you can see this. So another reason to do an echo. So what they basically concluded was that frequent PVCs and couplets do not require treatment, but do require careful follow-up. Sustained or high-rate ventricular tachycardia, even if asymptomatic, should be treated, and the prognosis appears to be generally favorable. I mean, they treated it. Whether it should be treated, I don't know, but I think we would all agree if someone's having sustained VT, we probably would treat that. It'd be hard not to treat that for fear that it could degenerate into something more serious. I think this reflects a general principle of arrhythmias in children in general, which is the earlier you have an arrhythmia in life in general, the more likely it is it will self-resolve. That's true for SVT, that's true for atrial flutter, and that's also true for PVCs. So, when you see a patient come into the office at 14 with PVCs, the chances of it resolving are substantially lower, particularly if it's idiopathic and not due to some acute thing like a myocarditis or something like that. Any questions on that? Okay. All right. Good job, Kitoki. So this is an 8-week-old who had a Ross-Kono, and in the middle of the strip, we see the patient is being paced. And the question I'm asking here is this ventricular tachycardia or is this jet, and why? I will ask our resident intensivist, Dr. Capon, if she can talk, to give us her thoughts on this.
Good morning, everyone.
Good morning.
Okay,
Now,
let
if
me.
Harvey wants to answer, he's allowed as well.
I just put Harvey back in bed, so he will not be joining, hopefully. But I apologize if you hear any squirming in the background. So looking at this strip, right off the bat, you can see pacing spikes. And sorry, I'm trying to zoom in here as much as I can. 8-week-old post-run is atrially paced. Okay, all right. So initially what I'm looking at is the QRS morphology, and particularly when we atrial pace, I want to see if there's any change in the QRS morphology, because that would indicate more likely this is a ventricular tachycardia rather than jet itself. From my view here, I think it looks like the QRS changes. Um, Let me just, yeah, no, the QRS definitely changes when we start atrial pacing. So that would make me think that this is more so a VT rather than jet itself.
That's exactly right. So again, when somebody is in jet, remember the other name for jet used more commonly in Europe is His bundle tachycardia, because presumably there's enhanced, or theory is that there's enhanced automaticity of the His bundle. And if you are depolarizing your ventricle from the His bundle, you should be going down the bundle branches normally. And so the QRS morphology in jet should be the same as that in sinus. The fact that the QRS morphology changes when you're going down the AV node and through the His Purkinje system suggests that the rhythm on the, before and after the pacing is not jet, but is in fact VT, because the QRS morphology is different in that rhythm than is in the rhythm that is going through the AV node. And it's also, again, a nice demonstration of how whatever is fastest wins when we're talking about automatic arrhythmias of the heart. So just by pacing the atrium at a rate faster than the ventricular tachycardia or the accelerated ventricular rhythm, we can normalize the QRS and get AV synchrony without the use of medications or things like that. So it's a nice demonstration of that. Any questions? Okay. All right. Here's a question. What are the borders of the triangle of Koch? I'm going to throw this one to Dr. Obsikov. First of all, what's in the triangle of Koch? And second, what are the borders of it?
Good morning. The triangle Koch is the anatomic structure in the right atrium. And it's I think it's kind of how you use it's what you use to determine where the AV node is.
That's right.
And it's bordered by the tricuspid valve annulus. There's that tendon of the Totoro.
Okay.
And then
what is the third border? Or the third corner?
is it the coronary sinus?
Yes. Funny, you got the tendon of Tartaro before you got the mouth of the coronary sinus. That's very good. So this is a nice anatomical drawing or a picture of it. And so again, we have the mouth of the coronary sinus, the anterior leaflet of the tricuspid valve, and the tendon of Tartaro. And the triangle of Koch is presumably in the top third to 2/3 of the triangle of Koch. And of course, you all know that when we do a slow pathway modification for the treatment of AVNRT, we're trying to put applications in the lowest third of Koch's triangle, because we believe there are fibers that are essential for AVNRT that are part of the slow pathway that allow us to modify it without injuring the good stuff, as it were, in the triangle. The reason, of course, that people can get heart block during ablations for AVNRT is because not everybody's heart follows these descriptions, right? The AV node can be lower in the triangle of Koch than usual. I mean, okay, so why could people get heart block? One is that the electrophysiologist is being careless, but assuming that they're good and they're trying to do their best and avoid that, the anatomy can be very variable. It's not uncommon for, in this case, it does look, in this drawing, it looks like a nice triangle here, but, or an almost triangle. But in some patients, we notice that the top of the triangle, and we can see that by where the His catheter is, because remember that the His catheter will be draped across the tricuspid valve in this general area here. So it sort of gives us a nice demonstration of the superiormost portion of the triangle of Koch. Some patients, the His catheter appears to be on the lateral projection almost at the same plane as the mouth of the coronary sinus, meaning that the entire triangle is crushed in a superior-inferior dimension. And when we see that, it's always a little bit frightening, because the question becomes, where can you safely place applications? Because the triangle, there doesn't appear to be very much space between the top and the bottom of the triangle. This is one of the reasons why I'm not excited at ablating very small children. There are lots of different reasons for that, but if somebody were to have AVNRT, of course, the triangle is going to be smaller. And if someone has one of these anatomical variants, which, by the way, is, as far as in my experience, impossible to predict from echo or any other thing, it can be very challenging to know where you can safely place your catheter to disrupt slow pathway conduction without injuring the node. So Now, other people might say, well, but in a small patient, you can use very little RF because the relative size of the tip of the catheter is greater and to a small patient, and so you don't have to be as precise. So there's certainly some truth to that. But bottom line is, it's an important thing to remember, and I can virtually guarantee you that this type of something about what we're discussing here will be in your boards in pediatric cardiology. So try to keep this in mind. So that's very good, Vlad. Any questions about that? Okay. This is a Holter tracing from a 15-year-old with an irregular heartbeat, and this comes from 3:30 in the morning. Patient, basically was determined to have an irregular heartbeat in their general pediatrician's office. They're not actually symptomatic. So my question to you is, what is this rhythm? How would you evaluate this? And how might you manage this? So why don't we ask Dr. Kaloff what he thinks about this?
Good morning, Dr. Bass.
How are you, Mama?
Right.
So you're sitting at your desk, you're reading the Holters, and this one comes up on your desk.
Okay, so the first beat looks like a sinus beat. Then certainly bradycardic. QRS is wide.
Mhm.
So I'd say some sort of ventricular rhythm.
Okay. So what would we call this rhythm? Is this VT?
It looks slower to I would say it's you'd call it an idioventricular rhythm.
That's right. Uh-huh. So what do you think about this happening at 3:30 in the morning in this Holter on this patient? Is this worrying you? Does it not worry you? Is there anything you need to do about this?
I'll say if he's sleeping and it's if he's asymptomatic, I would just check on him, call him, check on him, make sure he's not having any symptoms, and if it's if he's asymptomatic, I would probably I'm gonna see him in clinic, but I wouldn't do anything at the moment.
Yeah, I mean, generally speaking, this idioventricular rhythm is very similar rate to the sinus rate, right? It's on the right-hand side, the sinus picks up and it's a little faster, but on the left-hand side, one gets the sense that the sinus rate is quite slow because we don't see a QRS prior to this beat, right? So presumably the R to R interval is fairly long. So it's not uncommon that in the middle of the night, healthy patients can sometimes have sinus slowing, and you can have a little bit of an accelerated ventricular rhythm that is at a similar rate to the sinus rate. So when I see this on Zio patches or Holters in the middle of the night, I don't generally get too bent out of shape because it's not uncommon that your ventricular rate is, escape rate, particularly if the sinus rate is very, very slow, could be a similar rate to the sinus rate, and you could be in a ventricular rhythm. And we see this with some regularity. I would generally not do very much workup on this, especially as you say, Mohammed, if the patient is asymptomatic. And I would not treat this. I mean, obviously, we would want to know if the patient has any other arrhythmia conditions like long QT syndrome. There are things called pause-dependent ventricular tachycardia where people have very long pauses and then can have VT because there's an R wave on a T wave, QRS on a T wave. But in this case, this is really just acceleration of the ventricular, slightly higher than average ventricular escape rate that is essentially competing with the sinus rate. And during deep sleep, the sinus rate falls and the patient's in ventricular rhythm. But usually is not associated with any significant risk for the patient. One of the things that I wanted to show you, this is what a Holter looks like. Many of you may never have seen a Holter during your fellowship because we've moved to the Zeo patches. And one of the things that you may notice here, which is nice, is that the Holters, a traditional Holter had 2 or 3 channels which were nice because you could sometimes it would be easier to tell if the morphology of the QRS was changing, or just in general, it's always easier to assess an arrhythmia when you can look at the arrhythmia from multiple different vantage points of different leads. So that was one of the big advantages of Holters, was typically there would be, I think, 6 or 9 ECG stickers on the patient. Now, interestingly enough, in this particular example, all 3 channels look kind of the same. So it looks like we're looking at a very similar vector. So I'm not sure exactly how helpful these particular 3 channels would be. But that was one of the big advantages of Holters, and I would say one of the big differences between that and the Zeo patches. We actually do offer Holters here at Sinai, in case you're interested. We don't have very many of them. I think we have 3 functional Holters right now, which is one of the reasons we've moved to Zeo. But the main reason we've moved to Zeo is ease for the patient. The traditional Holter monitor, of course, all those EKG stickers have to attach to a device that is roughly the size of a cell phone or a little larger. And it's uncomfortable for the patient. They typically, I would say 30% of the time, but by the time the patient went to sleep, within a few hours, a couple of leads would come off, or you would have no tracing for 12 hours. If you were doing a 24-hour Holter, I would say 30% of the time you only got like 6 or 8 hours in children, because the leads would come off, or the child just took it off, or it was just too uncomfortable for the patient. So the degree of compliance with Zeos is like really extraordinarily better than, not to mention the fact that it allows us to do many, many days of recording, which traditionally Holters could only do 24 to 48 hours of recording. So the Holter Holters are sort of losing popularity because of those disadvantages. And the biggest disadvantage is that a Holter is very expensive. The device itself is like, in 2025, it's probably around $2,000 to $3,000. And typically hospitals have to purchase this, or alternatively, the other model is that you lease them from heart rate monitoring companies. But when a patient decides not to return their Holter, it's a big deal, right? Because you're losing $2,000 or $3,000, and the reimbursement in the United States on Holters is very small. And so if you lose a Holter, you could lose your entire, half your year's income from Holters. So Holters have sort of fallen out of fashion. The longer term monitors like the Zeo or the Barty are less expensive monitors. So there's a lot of advantages to them over the traditional Holter, but the one Holter advantage was that you could get multiple leads, which could sometimes be useful when you had a tricky arrhythmia to understand. Any questions about any of that? Okay. All right, I think we'll stop with that. We're at 7:30. Happy New Year to everybody, if I haven't seen you already this year, and we'll be back. Oh, so why did I ask? A Thursday, are you guys okay with doing angios as a makeup for last week?
I think that should work.
Okay, great. Okay. Very good. Hope everybody has a wonderful day.
Thank you.
Thank you.
Well, bye now.